Do you or a loved one struggle with life issues, like overcoming mental illness, addiction, and navigating relationships? Join Promises to Freedom. Each week, Kat and Cord will be joined by special guests to discuss and share provocative, informative, science-based, and spiritually proven methods that may help you find your promise to freedom. So tune in Saturday mornings, Promises to Freedom, brought to you by Zion Healing. The Promises to Freedom Show. A journey to full recovery with Cord Beatty and Kat Hart.
Good morning, good afternoon, and good evening. You've reached the Kat and Cord and Tank Show.
Welcome to Promises to Freedom Show. Today
I'm so excited.
I am too.
About this week. Yeah. I'm so excited. We were really excited. We talked about going to Florida on our last show when we had Jimmy here, and we're just kind of recording. What are we? We're just going on and on and on, hours and hours in studio, and we love it too. But we're really excited. You know, we went to Florida specifically to see Dr. Burgess and to see his new location. He's opened a Zion Healing Center down there. We love having credible physicians, and this gentleman is not just credible. He's loaded with so much education. Just to begin to hear half of what he's done, I'm like, wow.
Yeah. Well, I'm blown away that and welcome to the show this morning, Dr. Burgess.
Thank you so much for being here.
Thank you for being here.
He followed us back from Florida.
And I'm so blasted. I am so amazingly impressed that you're a Harvard University guy. And
tell us a little bit about you, because
tell us a little bit about you.
Yeah, we can't possibly do you justice.
Well, I think you can. I grew up in New Jersey. I did my undergraduate degree at Seton Hall University in South Orange, New Jersey. I obtained my medical degree from Harvard University, and I did an MBA program at Southern New Hampshire University.
Wow.
My residency training was in general surgery at Brown University. I also did subspecialty training in pediatric surgery under the subspecialty of ECMO, which is extracorporeal membrane oxygenation.
Which is what exactly? What is that?
That's where we put newborn on bypass.
Wow.
So it's used to treat babies who are born with premature lungs.
I was born with premature lungs. Wow. Yeah, 7.5 weeks.
So they
early.
don't just put them in an oxygen tank anymore. This is actually a bypass.
These
procedure.
are for babies who failed everything. So This is a baby who's been put on ventilators. They failed ventilators. They're essentially failed all the conventional treatments. At that point, the lungs are not useful, and we put them on a prolonged cardiopulmonary bypass.
Wow!
And what this does is that it gives their lungs a rest to mature. And once the lungs mature, we can take them off bypass.
Wow!
The dramatic history of that technique is extraordinary. We took a population with a death or mortality rate of 95% and changed it to a survival rate of 98%.
Oh, my gosh.
So it was an exciting area that we were involved with, and it was just a blessed time in my life in terms of training. I did surgery for a little bit, then decided to take a break and do some more subspecialty training. So I trained in emergency medicine, went through a program there, and spent quite a bit of time there, about over 10 years practicing emergency medicine.
Wow.
I decided I wanted to get back into surgery, but not just general type of surgery. I wanted to do more of a specialty training. So I did plastic surgery training for about 3 years, specializing in head and neck plastic surgery. We opened up a practice, quite a successful practice, and opened up several of them in the New England area. And we specialized in vascular surgery, specifically vein disease, as well as cosmetic and plastic surgery. During that period of time, we were dealing with what we were recognizing as addiction in plastic surgery patients.
Wow, from the opioid use.
Not from our opioid use, but from other opioid use. Also, sure. At that point, I started developing an interest in the opioid, started studying it quite a bit. This was over 10 years ago. At that time, I said, you know what, let's start a Suboxone program at our facility. And I was overwhelmed by the need and overwhelmed by the amount of patients that suffer from it and died from overdoses. Our Suboxone patient population continued to grow. We were quite successful, I think, in it, and we helped quite a bit of people.
How many patients did you have at this period of time in the New England area?
Our total patient population was about 10,000.
Oh my
No
gosh.
kidding. That's a lot. That's a lot of folks.
We had a good gig at our top time period. I had 6 surgeons working under me.
Wow.
And so we were kicking. We had a good time. But as one would say, times change, and we start to shift focus. And I said, you know what? It's me and my wife. We talked, and we decided that we always talked about going to Florida.
Yeah.
So let's go to Florida. But I didn't want to practice surgery. I wanted to get into something I was getting very inspired with, and that was opiate addiction. This was really becoming a big interest of mine. And I said, you know, maybe we can get into this business of addiction and depression, and I want to focus full time on that. But I don't want to do it alone because, one, the knowledge base is not where I think it should be, and I want to find a program or a group that I can team up with that has extensive experience in this, understands the significance of this, and looks at the treatment modalities more of an innovative approach as opposed to a conventional approach, because as we know, the conventional approach has a high failure rate and high recidivism.
Yeah.
I researched quite a bit of companies, came across Zion, looked at your vision, looked at your mission, your vision, your goals, your values, and it was very consistent with my own. So if there's going to be a good fit, there's going to be a good fit.
Yeah.
I've also been a very innovative person. I've been involved in research all my life, presented at national meetings and stuff. Where else could we be innovative and look and get such a team together to do this? And that's how it started.
Yeah. Yeah. Well, he's going to develop, Dr. Burgess is going to develop multiple centers in the northern Florida area, starting with the clinic that we were witnessing a couple of weeks ago in Jacksonville, which, by the way, of all of the franchise locations in the Zion Healing portfolio, the clinic that Dr. Burgess has put together in Jacksonville is my favorite.
You're not supposed to play favorites.
No, I got to play favorites with this. It has a feel.
Don't tell the other children.
It has a feel to it that was just completely relaxed from the minute you walked through the door. It was welcoming.
It's very chill neighborhood.
Very chilled out neighborhood. It was very welcoming.
But lots of medical practices.
There was
in the
nothing
area. It was
clinical
great.
about it. It was like stepping into a home. I just absolutely love that building. And I don't think it could have been done any better. But one of the things we want to talk about today, because of your specific specialties in opioid reduction, in the opioid addiction, you have some ideas about utilizing some of our technologies.
I do.
In this research.
Certainly do. A fascinating area. So we use Suboxone as medically assisted treatment for opioid use, and it has a high success. So when we look at individuals addicted to certain types of addictions, I should say, so let me clarify that. When we talk about chemical type of addictions, whether it be alcohol, in this case opioid, which is a big interest of mine, we know that there's a receptor change in the body that occurs. That's an acute change. And there's a negative feedback that occurs as well, which means when you start putting artificial opioids in your body, the normal endorphin response, which we will call our own opiate manufacturer, starts to decrease in quantity. So this negative feedback causes a more of a demand, more of a craving for the opioids, and the receptor increase from these artificial opioids also occurs. So it's the worst of both worlds.
So bad.
Now, if I could hitchhike with you for just a minute, does the side effect of opioids is they latch on to these receptors in the brain, and that are the pain receptors, right? And then they shut down a certain part of the brain, which is what? Which part of the brain?
There's a number of areas in the brain that it affects. When we talk about the midbrain areas, and those are the areas that it affects, but it can affect pretty much any area of the brain. Okay. So, for instance, opioids can give pain relief, which is physical pain. So we're talking about motor and sensory areas and of that nature. It also affects the limbic system. We get euphoria with it. So there are numerous receptors that the opioids will bind to. And So when we're taking heroin or something of that nature, or oxycodone or something, we're getting a pain relief as well as a euphoria. That euphoria is important. That's what's called the U receptor that we're speaking of. Suboxone selectively attaches to the receptor, the U receptor, so we get that feeling of euphoria, satisfaction, but it does not attach to the pain receptors, or it doesn't have a good binding to those types of receptors. So it is not a very good pain medication.
Okay.
But that euphoria indication seems to be or that receptor seems to be a big component of the addiction phenomena that we see. And it creates that, I wouldn't say gratification, because the addiction, they're craving more when they get it as opposed to being truly gratified. It's actually a paradoxical phenomenon. When we look at someone who's non-addicted, they get their fill. And they don't need it anymore. But when we look at the addicted patient, as soon as it's introduced into them, they start getting a craving for more. So it's a very interesting.
Like
they have
shark to blood.
because of the disease of addiction. They have the phenomenon of craving that comes along with that disease, right?
Oh, quite true. And it's actually quite curious, because it seems to be a pattern with any type of addiction, for that matter, which I found very fascinating. So we usually focus on the organic addictions of alcohol, opioids, benzodiazepines, and stuff of that nature. But that craving phenomenon, when it's introduced, we also see it what we would call psychological addictions, such as gambling and sexuality and things of that nature. So I find that quite fascinating, that the end result of addiction and the universal similarities of all addictions is that this craving when it's introduced to us. So we can never, ever be satisfied.
Yeah, there was a study done by a doctor back in the 1934s, Dr. Bob, and he took a group of people and put them in a hospital. And he had two sides of a hall in the hospital in Akron, Ohio, and he separated about 20 people at a time. And he would have them go on one side of the hall where there was a lot of alcohol, and he would have them drink as much alcohol as they want on the other side. So you could go on the side of the hall where there's alcohol. You could get one glass at a time of alcohol of any kind, but you could only drink it across the hall. And you could go into the hall, into this lounging area, and you could sit around and you could drink it. But when it was gone, you could only go back across the hall and get one glass at a time. You couldn't sit over there and drink more alcohol. And what he documented was that out of every 20 people, about 2 of every 20 went back and forth across the hall until they were so intoxicated that they fell down. And so he then wrote in his white papers that this phenomenon, he called it, of craving is prevalent in a certain class of people, which represented about 20% of his finding, or about 10% of his finding, about 2 people of every 20. And so he called it a certain class of people. He didn't understand back in those days that what he was talking about was the gene of addiction, or, the genetics of it. He just called them a class of people, but it's exactly what you're talking about.
It's truly phenomenal. And that genetic component, which we know is a big factor, it's not the only element in it. So we know there are other things going on, but that seems to be one of the major keys to set this process off.
Well, and with the opiate addict, with somebody who has an addiction to opiate, we've been in the treatment industry for 13 years, and by and large, the opiate addiction is the hardest addiction to overcome.
That's what we've witnessed.
It's what we've witnessed is that they have the most difficulty overcoming that addiction.
It's witnessed, backed by significant data. We have an explosive problem in our country. We are seeing numbers that we've never seen before, and quite frankly, the government, the communities were overwhelmed by the problem we're running into.
Right.
Spending a lot of money on it, aren't we?
Spending a ton of money on it. We're going to take a quick break. We'll be right back, but we're going to talk a little bit more about this phenomenon of craving.
If you're struggling from addiction or mental illness, or you finally refuse to allow someone you love to suffer any longer, visit our website at zionhealing.com. Zion Healing will change your life. We offer free assessment, individualized treatment plans, and accept most insurance. We'll spend the time needed with you or your loved ones to help you find the treatment and answers you're looking for. Don't wait another minute. ZionHealing.com, where recovery starts and addiction ends. The Promises to Freedom Show, a journey to full recovery with Cord Beatty and Kat Hart.
We're back with Dr. Burgess from Jacksonville, Florida. We're talking about opioids, the class of drug commonly prescribed for the relief of pain.
What it does to the brain.
What it does to the brain. Doc, the prefrontal cortex of the brain.
Yes.
Tell me, tell me the importance of that. Tell me, when it comes to opioid addiction or for the opioid user, what happens to the prefrontal cortex of the brain?
Well, the prefrontal cortex is the area of the brain. Again, they detect many receptors, but that's an area of the brain that's specifically affected by that, and that results in a lot of that euphoria feeling, that satisfaction feeling, from what we know, of the effects of that. But when that starts to happen, and the cravings start to happen, that results in a judgment issue in the patient as well, or the person as well, when they're taking that. And we start to see behavioral phenomena that follows the addiction.
So the prefrontal cortex of the brain is responsible for our behavior, basically, right?
Certainly. It's a big part of it.
Big part of our emotions, big part of our decision-making, cognitive behavior, right?
Well, it's important. I mean,
Yes.
you and I aren't scientists and we're not doctors, but the one thing that we understand being in the behavioral space is that it's 40% of the brain.
The
Like
prefrontal
that
cortex.
makes up 40% of the brain. And isn't it true, correct me if I'm wrong, and you are the expert, so I'm going to ask you, isn't it true that the prefrontal cortex is also the place where we create? So we're able to see into the future, the creative part of the brain mostly?
It's a wonderful part of the brain because it goes beyond the motors and the sensories. This is what actually makes us.
Like decision making.
This
right?
makes us. This makes our decision. This is what we do, how we feel.
The personality?
The personality. This is an incredibly important part of the brain. Very poorly understood. But we know when we talk about emotions, behaviors, how we address things, our rational decision making, this seems to be the hot pocket where all of that stuff is occurring.
Yeah, and so the opioids, as someone with an opioid addiction, when they're actively using opioids and they either become addicted to them or they have the addiction gene and they are an opioid addict to begin with, they just didn't know it. The prefrontal cortex of the brain is basically going to shut down on them when they're using large amounts of opiates. Right?
Of course.
So their behavior, then their decision-making abilities, their complex behaviors, all of that is out the window.
It gets severely affected.
Yeah. I read a report once by another doctor. He did a study on the midbrain, and he talked about the prefrontal cortex of the brain being shut down or severely impacted by opioids. And he talked about the midbrain then becoming the only really true functioning part of the brain at that state. And what I remembered about his speech on this was that he had identified these three areas of the midbrain functionality. One was a sex drive, the other was fight or flight, and the other was this hunger, which also could be the craving, And so what I came away from, correct me if I'm wrong, but what I came away from that thinking to myself at that time, and I've brought this up many times with my students, is that if that's really true and the prefrontal cortex of my brain is shut down from this drug, and I have no ability to...
You're basically a Neanderthal at that point, aren't you?
I've got this area of my brain called the midbrain that's in control that only has three basic functions to it that are very powerful functions, one being a sex drive and the other being a hunger or the craving part of this, and I'm out of control at that point.
You sound like a caveman, Cord.
Well, you certainly are. Remember, that part of the brain is there it's an evolutionary thing. So you see that in mammals, you see that in many animals. It's part of development. So those are unrestrained actions, which means if there's no control, they're just going to happen. the prefrontal area seems to, one, process the information, control the information, judge the information, and then decide how it should be done. So it's really the controller of that whole area of the brain. And
So
when
would you say it's the rational brain then, or that's where rationality comes from, or
I would say it is the rational
it
part
is
of the brain.
Okay.
Well, hence, why would a person who suffers from alcoholism like me, even facing severe consequences of another DUI or felony DUI in my case, I had multiple DUIs that led to felony charges and incarceration. And so why would somebody do that if they had any cognitive thinking going, if there was any behavioral, if I could control my rationale, if I could control that. So what you're talking about is exactly what happens to any a person with addiction or alcoholism. If that area of my brain is shut down because of this drug, then of course I'm going to get in my car and drive when I know that, because I don't have the ability to decipher how severe this next round of this is going to be. I'm not thinking about that. I don't have any ability to control my thinking. So I'm behind the wheel of a car, completely intoxicated, rolling down the road again, because that's what I do when I'm feeling good, and I'm feeling good about me, which drug and alcohol do to me. Then I'm in the car taking a drive, going where I want to go, and I'm completely intoxicated. Makes perfect sense.
It's 100%. That euphoria that we get from that addictive response that we're talking about, or from addiction, the euphoria we get from that, it shuts down our rational part and the loss of control. And when you talk to patients who suffer from addiction, one of the universal themes is this loss of control. They all feel it, right? I don't have control. I can't stop what I'm doing, and that's because that prefrontal part of the brain has been minimized, and it no longer has the control that it has anymore. So these the other parts of the brain now are overpowering our ability to act.
Yeah. And so opiates, and also if I remember right, opioids will bind to the receptors of the brain that are responsible for the dopamine, right?
Correct. It affects the dopamine response. We're still understanding. We still have a very naive, basic understanding of the effects of this, because there's more than what we measure. We know that other chemicals are being released. We know that receptor changes are occurring. I would go so far as to say that we know that even the neurologic connections start to change at that point as well, in the way we learn, the way we process things. So I think it has a much more of an effect. We certainly know that the electrical activity of the brain is significantly altered after the use of opioids as well.
Is that right? Wow.
So I sort of briefly heard about the study that you sort of talked about it peripherally anyway. I'd like to talk more. I know you would too, Cord, and I know Tank is interested in this in this study that you're wanting to do very soon here. Can you talk about that with us?
Certainly. So this is, from the long over 10 years experience with Suboxone, one of the...
Let me interrupt you for just a second. For our listeners, Doc, can you explain for our listeners exactly what Suboxone is?
Certainly. Suboxone is a buprenorphine naloxone combination product that when we take it, it gives us, it binds to those U receptors that are out of control to give us a satiated feeling of satisfaction without the high that we get.
So if I was an opioid user and you was to put me on Suboxone to get me off of the opioid use or the heroin use, if I'm a heroin user, then it's going to replace that synthetically, but it's not going to allow me to get high.
The buprenorphine does that. Now,
Okay.
It also has a naloxone component to the Suboxone, and that's to prevent you from cheating.
Okay.
So when
Wow.
if you take that opioid with the Suboxone, you're going to have a withdrawal.
Oh, wow.
Yeah.
That'll correct you.
It would precipitate a withdrawal.
Yeah, so remember, when someone is addicted, their judgment is off.
Yeah.
Right. So to say to them, well, I'm just going to give you buprenorphine and I trust you to do this behavior, we know that it's nothing about their moral spirit. We just know that they've been so affected by the addiction that that moral spirit, if you will, in their their prefrontal brain is not kicking in. It's not working. So they're going to be controlled from, by that midbrain area. So they lost control. So they will, and they do cheat, and they'll start to take the opioids. If you're just giving buprenorphine, they'll just overwhelm the buprenorphine and still get their high. So naloxone is important to cause that withdrawal. So they're going to think twice before they take that.
Well, that really connects some dots for me, Doc, because we ran inpatient treatment center. We ran a detox center for a long time, and our doctors never really talked to us about what you're talking about. We just knew that if somebody didn't wait 12 to 24 hours from their last opiate use, they were going to get violently ill from the switch over to Suboxone. And we witnessed it over and over again, where guys would come into the center
and lie.
And I would say, "Do we need to do a detox?" You've told me over the phone on the intake that you were using heroin for the last several years, and no, I've been sober for and maybe this is part of that prefrontal cortex shutdown, where there's no real rationale thinking going on here. When they would tell me who was running a center and lie to me and say, "No, I haven't used for the last week," and I would say, "Are you sure? Because this is going to make you very sick when our doctors put you on this. So I've got to introduce you to our doctor, Dr. So-and-so," and I would make the introduction. And he would have the Suboxone dose there, and he would then ask them, "When was your last use?" And it was, "It's been 2 weeks ago or a week ago." And he would do the same thing and say, "Are you sure? This is going to make you violently ill." And I got to tell you, for those listeners who haven't experienced this and are picking up on this, that maybe are opiate users or addicted to opiate, going from active opiate use to Suboxone without that break that I'm talking about, I don't think I've ever witnessed somebody so violently ill.
Yeah.
And like hospitalization, going to the emergency room ill. Yeah.
It can be quite significant. What's interesting, as you pointed out, which I've always found interesting, asking for the honest opinion in someone who's actively still using, well, the judgment is off. So more than likely, you're not going to get the true story. That's what's most interesting about it. They'll actually make a very poor judgment, no matter how many times you tell them that this is going to cause a reaction, and it happens.
And then I remember that because we got into a practice in the detox center of
drug testing,
of also doing a drug test prior, and then also making them wait for some period of time after intake before they could actually get their Suboxone. Usually the next day, to make sure we weren't making an unannounced visit to the ER.
Yeah, we didn't like doing that so much.
We're going to take a quick break. We'll be right back. We're talking more with Dr. Burgess from Jacksonville, Florida.
If you're struggling from addiction or mental illness, or you finally refuse to allow someone you love to suffer any longer, visit our website at zionhealing.com. Zion Healing will change your life. We offer free assessment, individualized treatment plans, and accept most insurance. We'll spend the time needed with you or your loved ones to help you find the treatment and answers you're looking for. Don't wait another minute. ZionHealing.com, where recovery starts and addiction ends. The Promises to Freedom Show, a journey to full recovery with Cord Beatty and Kat Hart.
So we've got Dr. Burgess here from Jacksonville, Florida. As you all know, if you're just joining us, this is an incredible physician who's got lots of accomplishments. So we ask you to go to the website and listen to the beginning of the program so you can catch up. But Dr. Burgess, if you can explain to us, if you don't mind sharing with us, about the research that you're about to kick off.
Oh, thank you. So one of the interests that we found with Suboxone, it's an extremely good bridge. But we also find that, so to give you an example, counseling alone has a very high failure rate in terms of opiate addiction. When we apply Suboxone with counseling, we have about an 85% success rate. So when we look at the downside of that, it's difficult to get a patient off of Suboxone. So they can be on Suboxone for life.
Wow.
And that's a very real situation.
What are the long-term effects? I'm sorry for interrupting, but what are the long-term effects? I mean, it couldn't be good. We're putting chemicals into the body, right?
Well, it is, and to hitchhike with you there for a minute, somebody who's been on Suboxone for a while, it becomes difficult for them to get off of that drug as well, without proper guidance from a medical professional.
True. So what happens is we wind up replacing one for another.
Right.
And we will still see the addiction if they try to stop, the craving if they try to stop.
Craving.
So those are the deficits. So the question comes into our minds, we're failing here. We're getting them to have normal lives. They're doing very well. They're obtaining jobs. That's how we measure it, seeing their families, getting their education. But they can't get off of this. So they're still addicted. It's a controlled addiction. They're being very productive in society, but it isn't ideal. So we would ask ourselves, when we look at the addiction phenomena and the way these things work, that it affects the electrical activity of the brain. And the question from a theoretical nature would be, if we were able to adjust or address this electrical activity of the brain, could we set in the mechanism of the body itself? Because one of the things we learn as a doctor is sometimes it's better to do little than a lot and let the body correct it. So if we were able to manipulate that electrical activity of the brain, would the body then have a feedback mechanism and correct itself? In essence, if we were able to correct the addiction electrical activity of the brain to that of a normal population, would we set in then mechanisms to take away that addiction phenomena, meaning the body itself is going to start addressing its receptor issues, its endorphin response, and other things, and say, you know what, we're going to maintain this electrical activity. Because we know when we look at electrical activity of the brain, that the body wants to maintain what it has, what it considers ideal. And it will trigger responses to the metabolic systems of the brain and other parts of the brain, whether it be the heart, whether it be the digestive system. It's going to affect every part of the brain. So the rationale would be it's going to also affect the receptors and the production of these other compounds, things we don't even know yet. And so the simplistic approach would be, let's see if we can manipulate this activity and cause this response to happen.
And you are thinking about using, your idea is to use TMS as a methodology to do that.
Transcranial magnetic stimulation, which, just to put it in a simple approach, is using a magnetic field to induce an electrical activity in the brain. So it's doing exactly what we would want it to do.
In that specific prefrontal cortex of the brain.
And that's what's so beautiful about TMS. We can actually focus that manipulation specifically where we think we need to manipulate it. And that is most attractive. It's the surgical precision. And from my background, that's something that's very appealing to me. So if we can surgically manipulate that electrical activity with TMS, could we create a feedback mechanism, meaning let the body take it from here, where that patient no longer is in need of Suboxone?
I love what you're talking about. You know, it makes me think about the quote, you know, there's a method to my madness and a madness to my method. You know, but you know, but it brings that to my prefrontal
pull my
cortex.
hair up.
That's what comes to mind. But I love what you're talking about, because if this actually, which for all intents and purposes, what you're talking about using the NeuralStar TMS would make sense to do that. To kickstart that area of the brain that's been shut down for some long period of time, you could revolutionize the entire process of how someone goes from active opioid addiction and opioid or heroin abuse to Suboxone as a methodology of getting them off, as a process of getting them off of those heroin or the opioids or whatever they're using, Percocet, whatever. All the way, and then gradually titrating them down to a point where you use TMS to take them off of all of that seamlessly and painlessly, and you're kickstarting that part of the brain that's been keeping them hooked on the Suboxone as their placebo, or they're satisfying their craving. right? That's what you're talking about. I think this is fascinating.
Well, single-handedly actually changing the way that opioids are handled.
You may
Opioid
revolutionize
addictions.
the entire treatment industry if you could.
Well, and
if-
save the
with
government
that
millions
work. Yeah.
of dollars.
Well, God's grace. So the phenomena we would like to see in something that is, to answer that is, if you, and we would see this in the behavior of a patient, right? So if you were able to correct that electrical activity, the patient say, you know what, I don't need this anymore. I'm feeling fine without it. And so we're now starting to see that phenomena that we see in patients that start to get off of things. I don't need this anymore. I'm
Right.
fine without it. I'm in control without it. That's the key response that we would look for in these patients.
Well, as a treatment center owner and as a person who's been an owner of treatment centers, inpatient and outpatient for over 13 years, I could tell you hundreds of cases. I could recite the story I'm about to tell you hundreds of times. But the individuals that are close to me and near and dear to my heart that come through our center, and they would go all the way through our program and become individuals that are then on Suboxone. And even though they've gone all the way through this program, even they haven't done TMS because they were not in the TMS program, but they were in our ILP program or our inpatient program, went all the way through the program, had a spiritual awakening, had changed their entire life. Families come back together. Guy's working and productive again, but he's got this demon in his back pocket called Suboxone in this little cellophane envelope, and he's got to have it with him every day. Mm-hmm. And I talk to these guys over and over and over again, and I mentor a lot of them, and I say, where are you at on your Suboxone use? And they say, it's just something that I'm not gonna. I am just absolutely convinced.
They're too afraid to come off
I'm
of
going
it.
to be on this. Alternatively, I've had people in our program where, when we were running our inpatient program, where we had in doing their med management in the mornings and in the afternoon, where we would actually get down to using a razor blade to cut a sliver of an under the tongue, fold of Suboxone, tape of Suboxone, and cut a sliver off of that that was so minute that you could hardly see it, and have them put it on the end of their finger and under their tongue, and that was good enough. But take the sliver away from them, and their world would fall apart. They would be in an immediate withdrawal. They would be sweating and almost in convulsions and curled up on a ball on the bed over and over and over again. I witnessed this over and over and over again. How can that small, minute piece of Suboxone be hanging on to you that tight? And it was also, and we all know it was psychological, right?
Well, the question that I would have for you as a medical professional is how much of that is, placebo? How much of it is, I guess really that's the question. How much of that is really placebo?
Essentially, if we look at the science behind it, we would probably say all of that is placebo effect, but could there be some micro amount of that that's causing some effect? I think that's going to be very debatable. But we do know that there is a significant effect of dependency that becomes mental. So remember, when we're dealing with the physical addiction, that's not the only part of it. Then there's also a mental component of addiction as well as a behavioral component. Mm-hmm. So we see the mental component, and that just really brings to clarity the fear that person has to go back into that dark place they were at. And they see it as a security blanket. Mm-hmm. So I would say that when a patient, and that happens frequently, when a patient gets that level, we have to create some form of security that lets this patient know that, hey, you're not going to fall through the hole. We're going to be doing something here that's going to work and make you less addicted. So the TMS, I do think, is going to have a physiologic effect on the brain and cause the effect of control. But I also think you're going to get a wonderful mental response from the patient as well.
Oh, I can see it. I can see it where you're talking about it kickstarting that area of the brain that's controlling this, the behavior we're talking about. The compulsive, the compulsive behavior is being, that part of the brain is being kickstarted and to function correctly.
Of course, because we know that the brain's activity that we're seeing with addiction, there's more than one thing causing it. We know we know there's the organic component of the opioid receptors, but we also know There's more than that. There's a mental component, a mental control. So when they go to that sliver amount, as you were talking about, we still have the mental component, which we really don't understand very well, that's causing that electrical activity as well, right? So when you're using TMS and alternating that entire component, I do believe you start to control the mental part that goes beyond the physical part. So one, you're controlling the mental part, but also you're kickstarting the physical components to control that addiction.
What I've known as a recovered alcoholic, a recovered individual that suffered for 25 years from alcohol addiction, drug addiction, all of it. Alcohol became a drug of choice for me in my addiction. The difference between the ability to have someone with alcoholism for their ability to get off of alcohol is so much drastically different than the opioid addict. For whatever reason, those opioids are hanging on to something, the receptors or whatever that is, and they're not letting go, where the alcohol is, I would tell people with alcoholism when they come in here, well, you know what, bro, this is going to be an easy ride. You got about a 72-hour window, and then it's all up. It's just all coasting and downhill from there. It's just going to take some solid work from you. It's going to be the easiest thing for you to get over in your life. It's going to take a little bit of a spiritual awakening and some education, but you're going to be just fine. The opioid addict, however, in the same conversation, I would be telling him, we got some stuff to do here because we're in for a bumpy ride on this deal. We're going to go through the same processes, but we're going to be dealing with a bigger, more horrible beast than
and that's why the study that Dr. Burgess is about to kick off is so exciting.
This is so exciting because if this works everything that you're saying makes complete sense, and your study is going to prove it, and it's going to revolutionize what we're doing, not only from our centers, from the Zion Healing Centers, but it will spill off into other.
Today the center, tomorrow the world. I have a question.
We just need to patent it or something so that some way to control that so that you can monetize it and then.
Well, we don't need to control the world's food supply, but still. Question that I have is, were you planning on using maybe the brain avatar, in other words, the live 3D image of the brain, so you could actually see the changes in the brain along the way, or what were your thoughts on that?
Your statement there is very good. And one of the things that we've learned, both as investigators and even the lay public for that matter, is data visualization is everything. So I want to visualize
worth
it.
1,000 words.
I can write. That's right. I can look at a lot of numbers, a lot of brainwaves. But if I can see that picture, that's going to help me a lot. And what's more, it's going to help the patient.
That makes sense.
So doing brain mapping using the Brain Master System, I mean, it makes sense to couple the both together, introduce it to the patient or the student, and as part of the process, and say we're going to take a look at this.
It really is exciting.
It is like the mad scientist just sitting in his basement,
going
yes,
can't wait.
Well, I think it's absolutely necessary. Absolutely necessary, because what we're dealing with is the patient. Right?
Yeah.
And the patient has to have gratification. And we can show them as many graphs as you want and, look at as many numbers. And maybe we're dealing with a scientist, a doctor, a physicist, whatever, who's going to understand what we're dealing with. But I would say that most of the patients are not there for that type of understanding. Yeah. So when you show a picture, as you said earlier, it's worth everything. And that also causes a gratification because it creates I'm winning. And that creates that mental phenomena.
Well, and the mapping shows them in color where this area of the brain that's not functioning correctly resides. It's showing us that in a 3D image. Imagine what you're talking about, using TMS and then being able to do a remapping pre and then during existence of the treatment, but then post treatment, and then be able to visualize that this area of the brain is functioning completely correct and healed, which is what we're after, and is in remission. This is an individual, then you're handing just real hard data to an individual who suffered so much, and they can move forward in their life knowing that they have fully recovered.
And the only next step for you is walking on water, Dr. Burgess.
Well, that's, I think I'll still be scuba diving. But in terms of what you just said, that's actually quite true. And just to not take too much of the time here, but when we look at the response to addiction and treatment therapies, what's the first thing we realize is a problem? There's almost nothing to measure.
Yeah.
You can't measure anything objectively. We're limited to surveys. How are you feeling? What's going on with your life? But we can't measure a blood study or something of that nature to show we're working. Now we're actually in a position where we're measuring, we're looking, we're seeing. This is hard data. This is hard data.
Yeah.
And it's looking at hard data in a way we've never seen it before.
Yeah, we're no longer just documenting and listening. We're psychological vigilantes. We are actually helping people.
Yeah.
Psychological
And it's
vigilantes.
fun, but it's
I'm going to
so
get a
fun.
T-shirt that reads psychological vigilante.
Give me one too.
I'll get you.
I'll carry the banner with Tank.
Very exciting stuff. Unbelievably exciting stuff. So, Doc, so the treatment center in Jacksonville, Florida, you can go to our website, zionhealing.com, and we have a tab that you pull down that looks at locations. The Jacksonville office is on that location finder. You can call the 833-446-3733 number, which is our toll-free intake number.
And that number again is?
It's 833-446-3733. And we will take your call and reroute it back to you.
Wait, I have another question too. Dr. Burgess, are you going to be accepting patients into this study? In other words, if somebody's in New York and they want to be part of the study, is that something that they can do?
Oh, absolutely. This is all inclusive.
You're going to do, and you'll be accepting all insurance policies down there at the clinic in Jacksonville.
Of course. Of course.
Private pay or insurance-based. I noticed when I was there, you have care credit for the individuals that need to private pay and want financing.
We do.
And so we have financing options at that clinic as well. A lot of folks take advantage of that. Insurance sometimes doesn't pay everything we need it to pay, and so there's some great financing options to do that you can take advantage of down there. It's going to be an unbelievably good, great clinic down there. It's in such a needed area. I could tell by the neighborhood down there when I drove through it that this was such a perfect place for you to choose to put this clinic. Mm-hmm. And it was a needed area in Jacksonville. I looked at the demographics of that city as well, and high opiate use in that neighborhood of Jacksonville. And so you've got a great thing going on down there.
I just love the fact that you are a pioneer, and it's exciting to me and also very inspirational that you are who you are. You've had a conventional education like a whole lot of other doctors out there, but you're also leading the field of new medicine, which is really caring about the individual and not just treating the symptoms, but actually treating the cause, getting down to it, and creating lives. Not just better lives, but some people wouldn't even have lives if they never met you.
Well, that's correct. And so, to commend you for that, we do need to do that because we don't, in the behavioral health, we've been in this industry for a long time. We don't find that many doctors that care the way that you care.
Well, they don't want to color outside the lines, and you're all over it. Yeah. You're shiny.
They're always usually by the book of doing things with a script pad, and this is the only way to do this, and so it's commendable because it's rare that we find doctors like yourself that are willing to step outside of that and say, I care enough to do something different. And I care about you, and I want you to get well. Mm-hmm. And instead of come back, keep coming back. That message. And so, it's our hats are off to you, Doc.
Well, thank you very much. And again, the spirit of Zion is what drove me to Zion and to work with you all.
Yeah. Please send your emails in to us at
info@zionhealing.com. Well, we're going to set the world on fire. Upward and onward to the greater cause of mankind, Doc.
And if you want to get in touch with Dr. Burgess, you can go to our website and get his contact information for the Jacksonville office for Zion Healing, or you can contact us directly and we will point the emails in his direction. When are you planning on actually kicking off this study?
We're planning almost immediately. We're just looking at potential NIH grants to take the financial burden off of patients and other things. And truly, in the spirit of Zion, we want to treat everyone, regardless of financial ability.
Next week when we come back, we're going to have Bill Marklis. He's the owner of Brainmaster Technologies.
One of the owners?
Mm-hmm. One of the owners. His father-in-law was the founder of the company.
No, his stepfather.
His stepfather
That's
was
all
the
right.
founder
I'm
of
here
the
to
company.
correct you.
Thank you.
It's all good.
And Bill's going to be with us, and we're going to be talking about QEEG, or what's the
Quantitative electroencephalogram therapy.
And he's going to be taking us through brain mapping, the brain avatar system. And what it
3D
does.
live image of your brain right here, right now. But wait, there's more.
I believe you've been introduced to that, Dr. Burgess.
I certainly have.
Yeah, it's an impressive technology that Bill's put together. We've been doing neurofeedback for a lot of years, but when we met Bill and saw the brain avatar system, it was like night and day difference. From
It was the
anything
brain on steroids. It took me a while to get you to look at it. But what are your thoughts on that, Dr. Burgess?
Exciting diagnostics, exciting. There's also a component of the algorithms that actually let us, for the first time, visualize the mid parts of the brain as opposed to the external parts of the brain, which is traditional. Yeah. Quite impressive. The visualization is outstanding. The algorithms and the data behind that, unquestionable. The studies, the quality of what we're seeing, and what we want to do with the system in terms of treating our patients. This really is a phenomenal tool.
Absolutely, and we looked at we've used several different neurofeedback equipment manufacturers we've never seen anything like it when we met Bill. We just had to have
studied.
it.
It's the most extensive.
It was the most extensive.
To mention pretty colors.
Science and technology. Bill was
he drank the Kool-Aid.
He drank our Kool-Aid. He loves our company. We are lockstep in partnership with him. And again, we're going to set the world on fire in neurofeedback.
We're excited, super high efficacy level, and that's what we're after, right? I mean, isn't that what we're all after?
Well, this is exactly what we would look for: something that diagnostically would be used to look at the results. Replace, basically, again, one of the difficulties in looking at these patients who suffer. And in this case, my interest of addiction, but others as well, is how do we quantitate their improvement? Is there an objective analysis that we can do? And this allows us to actually do that. And besides, as you said, they're pretty colors.
I love this guy. We got to have him back. He's my kind of people.
We will. We'll do many shows with you, Doc, in the future. But next week we'll be with Bill Markless from Brainmaster until we meet again. Everybody stay safe, stay sober.
Happy trails.
God bless.